the nerves but does not adhere to them in tubercular form. Spread very often in the skin of the face where it causes thickening and corrugation of the skin at a TB. So eventually this one also will also cause thickening of the skin, and at the end of the day there will be loss of sensation, and the person will not feel any pain. The progress of leprosy is slow, very slow. It may be years before a child infected by parents show the first sign. I said it the other time. That's one of those things that it makes it unique. It's not something that you get within months or 1 year. You think that you manifest symptoms. Uh, this one can take years before the symptoms can come out, and often the child has grown into adult before the disease is recognized. You can see a child contracted the disease as a child, but it is when it is adult that the disease is manifesting itself. The mechanism by which it does this, nobody knows. Yeah, that's why nobody knows that one is even infected with M. leprae until the person starts showing all this thickening and loss of extremities and all whatnot. So we go to therapy on like M tuberculosis. We have anti-leprosy drugs, and they also have multi-drug regimen like M tuberculosis, and some of the drugs are the one they call dapsone and rifampicin. The rifampicin also can be used because it's still a tobacco bacilli, sound like the other one. The only one that this one is causing leprosy, the other one is causing tuberculosis. And then they are given for a total of 6 months for 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 patients with localized form of leprosy. So that means that if it is localized, the bacilli are very few. So they can treat them with dapsone and rifampicin for 6 months. But if the patient has widespread disease and large number of bacilli are involved, three drugs are advocated: dapsone, clofazimine, and rifampicin. They are given for 24 months. That's 2 solid years. Most patients are able to tolerate the drug well, but a few experience undesirable side effects or even exacerbation of symptoms. Are we there?
Yes, sir,
Uh,
we are there.
have you learned new things on M tuberculosis today, or you have not learned anything? I know some of us that are in TB lab, it's like a refresher course to you. But for those of us that are not in TB lab, are we there?
Sir,
Hello?
we
Yes, this is where we are going to draw curtains on today's lecture until tomorrow. So if you have any question, let us know and let us have the conversation. Nobody knows it all. We'll continue to contribute. Others that have experience in TB lab can also weigh in trying to make us understand some of these things. Any questions? Hello. I hope we have not slept.
no, sir, we are with you.
Ah,
Yeah,
but- because I'm not hearing anybody again. I hope we have not slept too.
No, sir.
Aha.
very true, sir.
Okay, that's good. Uh, do you have any question for me?
Yes, sir. I have one question.
Who is asking question?
This is Akile has some question.
Mrs. Akinloye.
My question. Yeah.
Akinleye, not Akinleye.
Akinloye. Okay.
Yes.
Mrs. Akinloye.
My question is, why is it that is early morning sputum is preferable for TB?
Well, why is preferable is that it is believed that there will be concentration of the bacilli in the early morning because the patient must have slept overnight. Are you getting it? In the early morning, the bacilli are still concentrated. So you know he has not been coughing or be coughing out. Are you getting it? By the time he's in the morning, he will be coughing out, and the tobacco bacilli will be going with the sputum as he's coughing out. But early in the morning, it's still concentrated. So once it expectorates the sputum into the cup, at least they can recover good number of bacilli. Or do you have different view? Mr. Akinleye, I know you have been working in TB lab, and
I
your
don't have
project
any
topic and
curious
and your
about.
project topic is on TB.
Yes, so it's on TB.
I know all of you that has TB. That's why I said that all of 1/3 of the class is working on TB.
Yeah. Actually,
From
I'm
the
not in lab, but I'm interested in making findings on it.
I think that is the answer, and we can still research on it. Why is it preferable? Why do you ask the patient to give early morning sputum? So I think it's because the bacilli are concentrated in the early morning. The once the patient has woken up and is not, he will be coughing, and there's no way he will be swallowing the coffee. He will be throwing it out. So the density will be decreasing. That's what I think. Any other question? Yeah,
Thank you,
I
sir.
can, I can be mentioning all of you
Yes,
that are
sir.
working in TB lab. I know all of you. In fact, if I'm telling you all of you that are working in TB now, that your project is on TB, you will marvel. This man don't even, he has even gone ahead to even uh, I'm listening to you. If there is any question, and if there is no question, we will call it a day. But I know that a lot of you are even supposed to be teaching me TB, because I left TB lab in 2003 or 2003 or thereabout. Mrs. Akinleye, you are working on prevalence of rifampicin resistance among presumptive patients using gene expert in a solo general hospital, isn't it?
Yes, sir.
Okay, Tola, you don't know what you want to do. You submitted 2 topics, one on TB, the other one on virology.
I didn't submit on TV.
Ah,
I didn't
why
submit
is your
on
name?
TV.
Why is your name appearing on TB?
No, maybe it's a mistake.
Okay, maybe it's a mistake. All right, no
Okay.
one. Maybe it's a mistake. Then okay, no, it's a mistake. Your own is a phenotypic detection of metallo beta lactamase producers
Uh,
among gram negative. Is that not your own? Although I saw another one on virology. You pick topic on biology, you pick topic on bacteriology. There's one Olusegun Grace Olufunke, molecular detection of rifampicin resistant mycobacterium. There's another Ojetayo Elling,
Yes, sir.
prevalence of rifampicin resistant mycobacterium tuberculosis. Then we have Adigo Andrew Olushola, prevalence of pulmonary mycobacterial infection. Abose Akinloye, prevalence of mycobacterium tuberculosis using GeneXpert. Dada Johnson, molecular prevalence of rifampicin resistant mycobacterium tuberculosis. Adebiyi Oludele Emmanuel, prevalence of drug resistant tuberculosis. Then Shitu Ahmed Adeoye, we have prevalence of rifampicin resistant MTB. You can see when I said that too, it's even more than 1/3. This is about half of the class. Okay, let's say 1/3. So you can see that I am dealing with experts in tuberculosis, because virtually at least 1/3 of the class is doing something that has to do with TB. Anyway, it's good. At least every one of you is reporting from different center. So let's see what the result will be like. So, any other question?
Sir, are you our supervisor? Because you have not been given supervisor.
I know I'm going to supervise all the TB, those that are having TB.
Okay.
And I know I'm going to supervise all those that are having AMR as their topic.
Okay.
So I am giving you expo.
Okay. What about that then?
Okay, sir.
Others,
Thank you.
anyone that is others is not my calling now. Everybody has his own research interest.
No problem, sir.
Alimi,
Sir.
which one are you doing?
H. pylori.
H. pylori. Okay.
Yes.
H. pylori. Ṣé o ṣe
Yes.
àwọn parasology kan nìyẹn ni?
Not parasology. It's micro.
It's micro. H. pylori.
Yes.
Ẹ̀yin ẹ máa lọ lo kit nìyẹn náà. Àwọn iṣẹ́ kit.
Virtually everybody is into TB, so let me go to another.
You know, I said it now. Ṣé wọn náà wà ní TB program ni?
Yes, sir.
Ó ga o. I was expecting at least I was expecting majority of you to go into antimicrobial resistance. Although most of the TB work that are there is also on resistance, so that's why I pick interest in it. Because most of the TB work is either rifampicin resistant or this resistant, and my own research focus is resistance, generally to microbial resistance. So I pick interest in all those ones. But anything, you cannot be jack of all trade, master of none. In research, you must have a focus. So not that anything that comes, you do. Anything that comes, you do. You will not have focus. So it's better you get yourself into your own area so that you can be working on that area consistently. Not that tomorrow parasitology will come, you jump at it. Virology will come, you jump at it. You just be jumping. So, but when there is that does not mean that I cannot supervise parasitology or virology. If the student wants me to supervise him, if the student wants me to supervise, I can supervise. Are you getting it? But I must let the person know that my area of interest is antimicrobial resistance.
Resistance.
So tomorrow is another day.
Okay.
8 o'clock as usual.
All right.
Let's see what we can do tomorrow and Sunday, God willing. Then we can
Amen.
rest. We can rest. Let other lecturer, at least I don't cover a lot now. I don't cover a lot of grants. So
Yes, sir.
let other lecturers also take some time to teach.
I
Okay.
want you to supervise me, sir.
Who is that one? Who is that one?
Akorede, sir. Akorede.
Adi Akorede,
Akale, sir.
Adekunbi, Alaja.
Yes, sir.
What is your topic?
Madam Loan. Comparison of audit and my microscopy in a malaria parasite.
Àwọn ẹ̀yin oníkìtì ni
Fẹ́ ṣiṣẹ́ ni.
ẹ fẹ́ ṣiṣẹ́. Ó dẹ́ kẹ́ ṣiṣẹ́.
Kó má dáyàn láàmú ni.
Ó dẹ́ kẹ́ ṣiṣẹ́. Ẹ bá ṣiṣẹ́ ẹ náà lẹ́yìn náà inú yín máa fi dùn pé ẹ ṣiṣẹ́.
Iṣẹ́ náà ni. But it's just not as
Mo sọ pé kì í ṣiṣẹ́.
tedious as TB.
Mi
Bẹ́ẹ̀ ni,
sọ
sir.
pé kì í ṣiṣẹ́. But you cannot compare that kind of iṣẹ́ to those that are working on TB. Although I know why most of them work on TB, because most of the materials they will use is the same material they are using for their patients.
Using
I know.
yeah, then.
I know now. I know. I work in chest clinic for like 3 years or 4. Oh, I know that most of the patients that are coming there, they are going to be their research patients. Most of the sample that are coming there is their sample that they will use. So everything that is available for that patient is what they will use. Okay, now. Ebi tá bá ti ń ṣe náà la ti ń jẹ. So if you think that that's what you can do conveniently, but you need to do extensive literature review on them so that
Yes, sir.
we actually know what has been done before and what you want to contribute to knowledge. Let us see what has been done on this RUDT and microscopy before, whether in Africa, in Europe, in Asia. Your literature review should be able to tell us. And then at the end of the day, you let us know what you want to that will be in your introduction anyway, what you are likely going to contribute to knowledge, which area, where you have observed the gap, and where you want to plug in. Is it that we don't have enough of this data in southwestern Nigeria or in Nigeria as a whole, that maybe extensive work has been done elsewhere, but scanty work don't let me supervision. No.
Sir. That's just
So that is so you need to let us know what you are actually bringing to table that makes you want to work on that. It might be they have worked on that thing before, but it's been a long time. You want to see whether the result you have gotten that long time ago is still valid, or we have scanty data that is not something that we can actually say that we have data. That's why you want to also do it. And you can say that it has been done elsewhere. Maybe it has not been done in your own locality. That to the best of your knowledge, such is not done in your locality. Where are you working, Ajia?
Ogun State, sir.
Where in Ogun State?
HMB, sir.
Which of the
General
hospital?
Hospital,
General
Hospital,
Okay, General. So it's not been done in that part of the Ogun State generally, that you have searched the literature, something like that has not been done in Ogun State as a whole or something. You can It's research. You cannot tell us that you are the first person to do it. You will continue to research and research on it. So far so good. We'll see tomorrow.
Yes, sir. Same time tomorrow.
Yes, same time
I have
tomorrow.
information for the
I
class.
just guess.
You say?
I have information for the class. Tomorrow
Okay.
morning, I will inform you if you are going to have parasitology. The lecturer will get back to me concerning the time. We are having parasitology tomorrow or Sunday. Thank
Okay.
you.
All right.
All right, ma. Thank you.
All right. Good night, all.
Good night, sir. Thank you so much.
Good night, sir.
All right. Good night.
Ajilayo.
This guy, before you say good night, Omotosho, why are you hiding? Ajibola, Aboti Suni.
What's this, sir?
Ó sọ̀rọ̀ ni, Jíbọ́lá. Kí ló ṣẹlẹ̀? Hello?
Ẹ kálẹ́ sà.
Mo ní ó sọ̀rọ̀ ni, kí ló ṣẹlẹ̀?
I'm with you in the spirit, sir.
Prophetess, Lady Evangelist, Mother in Israel.
Good
Okay,
evening, sir.
good evening. Báwo ni? Family
I'm good,
ńkọ́?
sir.
Ẹ pẹ̀lẹ́.
We bless God, sir.
All right, good night.
Good night, sir. Thank you, sir.
Yes, sir. Ó dàárọ̀, sir. Ajilayo.
All right, ó
Dàárọ̀
dàárọ̀.
gbogbo ilé. Ìmọ̀ ayọ̀ ọlá mọ̀ sùn.